Right, next up, which of the following best explains the change in murmur characteristics when the patient is asked to stand from a squatting position? Okay, now I know it's a cardio question. And this one is a maneuver murmur intensity question. They love to ask these. So stand from a squatting position. So we're squatting and then standing. Okay, and that's important. I read the last sentence, the question part, multiple times before I pick an answer because they are intentionally tricky with their questions. I don't really need to look at these. I just need to know what the murmur is. And very briefly here, if you skim this, I mean, you see it right away. Mid to late systolic murmur heard at the apex, followed by a mid systolic click. Some people memorize all this stuff. I don't know how you guys do it. Power to you. I could never. I do my best to try and understand what's happening here best as I can. There's really not too much that you need to memorize. You need to know what's happening during the cardiac cycle, and then you need to know the valve locations. So coming over here to APTM, from the right side of the patient to the left side of the patient, we have all physicians take money. Again, that's all physicians take money. If you know the intercostal spaces, good for you. If not, I'm sure an attending will chew you out someday. But we're at the apex. So if we were to draw our heart here, it would look something like this, maybe less football shaped. Our apex is right down here. That's the mitral valve. Okay, so we know we're talking about the mitral valve, and it is a systolic murmur at the mitral valve. So now we have to think what's happening during systole. Are we talking about atrial systole or ventricular systole? If you've ever had that question, the answer is always ventricular systole. They're always talking about ventricular systole or ventricular diastole, unless they specify atrial, but they never do. So what are the ventricles? So just think the ventricles and the atria are doing opposite things. So what are the ventricles doing during systole? That's right. Dora the Explorer style, the ventricles are contracting. Therefore, the atria are relaxing. Okay, so the atria are relaxed. The mitral valve is supposed to be shut then. Right? It's not supposed to have blood moving through it, but it is. And so if blood is moving through it during systole, as blood is trying to escape through the aortic valve, say aortic valve's right here, and some of it's going out, that must mean we have a mitral regurg or mitral valve prolapse. They're pretty much synonymous for the sake of the exam. So we've got our loaded baked potato from Texas Roadhouse here, and I have it partially full. The glass is half empty here. The yellow bits are the chorda tendineae, and then this represents our mitral valve. That's our floppy mitral valve in green. Now, the question was asking us, what happens when we go from squatting to standing? There's a lot to unpack here, but I need you to understand that squatting, like get out of your chair for a second, squat down, and just feel your thighs. Trust me on this. You should feel that your thighs are a little more tense. They're stretched, they're contracted. That is squeezing the arteries and veins in your thighs. When you squeeze a vein, you push blood back up towards the heart. Veins have valves in them. They can't go backwards. So when you squeeze your veins in your legs, the only direction blood can go is back towards the heart. So when you squat, you actually increase your venous return. Venous return is synonymous with preload and diastolic volume. Like all those terms are very similar. So again, these terms are synonymous for the sake of the exam. Cardiologists are welcome to make fun of me, but this is how I understand it, and it works. So squatting, you clamp down on your veins, you squeeze blood back to your heart, you increase your preload. You also increase your afterload, because when you squat, you're not only squeezing veins in your lower extremities, but you're also squeezing the arteries. Arteries are afterload. It's like adding resistors in circuit. When you clamp down on one part of the circuit or add a resistor to it, you increase the work that the heart has to do to pump blood against it. So our arterial vasoconstriction, or just putting pressure on the arteries in this case, equals our afterload. So squatting increases preload and afterload. Easy enough. We were asked to go from standing to squatting. So we're going to decrease our preload and decrease our afterload. Now, this is a complicated question because you needed to know that mitral valve prolapse is a oddball. Mitral valve prolapse and HOCM are the odd ones out. If there's anything to remember here, it's that those two are strange. I'm going to explain why MVP is strange, and then I'm sure in a different video we'll talk about HOCM. So again, here's our heart. with our yellow chordae tendineae, we've got some blood and our flimsy mitral valves. If you increase your preload, now we definitely have a potato with really tight chordae tendineae. And you can also think of like these blue arrows coming in here. These are the walls being pulled in either direction. And it actually, if you're to kind of go back and forth here, it pulls these mitral valves into a more taut position. So they actually let less blood through. And that's why this is weird. More blood usually increases the murmur, except for MVP and hokum. So again, more blood will make the valves more tight and work better. So in this case, we're decreasing our preload, which does what to the intensity of the murmur? Right again, Dora. It increases the murmur by decreasing preload because this is an exception. So let's go back to our question here. Maneuver effect. We talked about it. We are decreasing our preload. So it's either A, right away. We can cross out all of these answer choices. It's not C. We said we are doing what to afterload? We're decreasing it as well. So it's not B. Okay, so we've got 3 left. Murmur timing and change. We didn't talk about this yet. Let's just assume that we don't know what this is. We don't even know. So go to the thing that you know. We talked about the maneuver. We know the maneuver. We know the murmur intensity is going to get louder. So we can cross off anything that says softer. Great. Okay. So now we are down to 2. This is a great place to be. Even if you have no idea, it's either earlier or later. Just pick one, move on if you have no clue. But let's think about it logically. If you are making your murmur worse, if more blood is regurgitating through the mitral valve, do you think you would hear the murmur sooner or later? Just, you have no idea. You have no idea what's happening. What makes sense? The murmur is getting worse. Would it happen sooner or later? The answer is sooner. The valve is floppy. We're going back to our picture here. The valve goes from this in squatting to this when we stand up. The valve sucks again. So as soon as the left ventricle starts contracting, blood's going to start spewing through it. That's why it happens earlier. So our answer is A.